you want to introduce yourself, go right ahead. Thank you.
So I'm Michelle Brain. I'm the Midwife Hypnotist. I'm a registered nurse and midwife. I've been a midwife for 20 years and a nurse for 30 years. I've worked all over Australia through the Indigenous communities, regional hospitals, remote hospitals, and in city hospitals. And I guess my frustration with, I'm also a mother of 13, so I've given birth to 13 children. My frustration with midwifery over the last 20 years has led me now down the path of really looking at where I'm at the moment is low socioeconomic area. So, you know, they don't have access to home birthing. So in Australia, home birthing is very expensive because the insurance around it, they don't want home birthing. So we don't have access to that. Hypnobirthing can be quite expensive as well. So in the last few years, I've really been looking at what would change for those women that come into birth that they can afford something that's different. And so after doing the hypnobirthing and then following it through to be a hypnotist, I've worked with a lot of women in birthing with traumas and for birthing, but I've found now that I can walk into a birth suite with someone who's totally out of control. You know, they come in 2 centimeters and they're screaming want the epidural because that's all they know. And with using trance, within 30 seconds it takes me, they are in control and will proceed to have a normal birth. 30 seconds. So, and look, I've done that over the last 20 years. It's probably a skill a lot of midwives have, but after doing my hypnosis, hypnotherapy, and continue to study in that, I've just found that it's made the difference. It's just made the difference. Women come in and I can walk into a birth suite and the girls come and get me now, which is good. At first they didn't. They just thought, yeah, another hypnobirthing, you know, it's crap. And but now they'll actually come and get me. Or the doctors will come and get me. They'll say, Michelle, we need you in here. Could you sort her out? So it's been lovely. So I was just saying, I've just put together a course now that's just for women to do. I mean, midwives can do it and hypnotherapists can do it as well, but it's aimed at those women. So instead of, you know, the $1,200 for the hypnobirthing, which is that's what they charge here. I don't know what they charge over there. It's just $150 and they sit down in front of the computer. They have a 15-minute video and then they have a recording of a trance for them to practice going in and out of trance, so that when they go to have their baby, they understand the place that you go to have a baby. And it also sets anchors from their partners, because once I'm in a room, I set an anchor, like I might put a hand on a shoulder or something, and I'll pass that on to the partner or the mother. So I step back then and they take over and they do it together. So it's really lovely. Once they've got that anchor, they just, in between, you know, they all do it a different way, in between contractions, during contractions, things like that. So I'm in the process, I think, of just resigning from the hospital system, because here we seem to be going backwards. I feel we're going backwards in the last 15 years, and inductions for everything, you know. So one of the last births I did, the girl was a midwife for 2 years. She had 5 of her own children. And that was the first normal birth she'd seen with me in the room, 2 years of being full-time midwife. So I'm not sure. We've talked a little bit about what's going on there, let alone getting through all the legal stuff. I just don't know how you do it across the states. Here we have a few, we're all registered in Australia together, so we all work under the same banner. We don't have those issues, but we still have, you know, home birthing is still an issue. And if you live remote, there's not the services out there. Often we deliver remote, but it's not because they're supposed to, it's because the women refuse to go to hospital. So, yeah. So anyway, that's me, the midwife hypnotist.
Well, I have a couple questions and then I'll put it to everyone. I think what we're used to is there's hypnobabies and hypnobirthing in the United States. They'll spend about $300 to $600 for the course, depending on if it's online, in person. But there's so much in-depth commitment to the versions we have here. I personally did it with my second and third, the hypnobirthing, and the repetition and starting it early. And you've never even met these people before. So like, how do you have that influence on them? I mean, as midwives, we would love to walk in and put our shoulders on and make their pain go away and make them go, like, teach us these talents and skills, how you do that.
And that's why I'm doing the course. But to put it in a nutshell, what happens is for somebody to go into a trance, it's a focused state. So if you're driving a car on a long road and you're focused on the road, you will slip into a trance and your unconscious will drive the car. And you'll all of a sudden go, oh, did I go past that road? You know, you missed something. Have you all experienced that?
Oh, all the time. Yeah, we drive home and we're like, how did I get home? Yeah.
Yeah. Okay. So it's because you're focusing. So you're in a focused state and you slip into a trance very quickly. So if I was to hypnotize somebody, I would simply get them to focus. So whether they focus, you know, the old TikTok, or whether they focus on a dot on the wall, or whether they focus on their eyes, whatever it is. But the thing is, when they come into labor, they're already in a focused state. And this is where the medical profession get away with so much. So they're focused on pain. All right. So they're still in a trance, but they're in that trance. They're in the trance of pain. Now, when you're in that focused state, you're very suggestible. And that's why you see people that get up on stage and quack like ducks, because they're very suggestible. You'll suggest something and they're more likely to do it. So what happens is women come in to labor, all of a sudden not knowing, you know, they haven't done the hypnobirthing, or even if they have, and they're focused on this pain. They don't understand how to shift their focus. So they're focused on this pain. And then the doctors say, oh, you need an epidural. Oh, okay. So they're in that suggestible, yeah. So that's why you agree to things in the birth suite and go, well, I didn't want that. That wasn't in my plan, you know. So unless you've got a midwife there that's got your back, or you've got a partner that knows his stuff or her stuff, and not, you know, that knows what you want and's got your back, then it's so easy for them to manipulate you. So all I'm doing is using that same focus state. So when they come in, they're focusing on the pain. So I just stop them and I'll just say, okay, we can do this two ways. You can continue to go this way, which doesn't look like it's working for you, or I can show you another way. Now, in the last 20 years, I never used the word trance and I never used the word hypnosis, because it was just my way. It was the way that I worked. But now, because I have formal qualifications, I have to, you know, I have to say something. So I have to say deep breathing, or trance is a better word than hypnosis. So I'll say, we could use a trance, or have you been hypnotized before? Something like that. And they say yes. And I say, okay, just follow me. So look at me in the eyes. And this is, they can be like to go into, you know, a contraction. And I'll just say, okay, watch me and breathe with me. And so they're focused, and they are so focused, because, you know, they come in and they're like, just help me. And so that, breathe with me, that's it. And then I'll gently put my hand on my shoulder, and now just feel that relaxation flowing through your body. So basically I hypnotize them that quick. And then every tightening, I deepen it. And this, I use this. And then so they're already done. They're already focused. They're already breathing. They're focused on their breathing. They're great. And then the next 4 or 5 contractions, I deepen them and say, and just go deeper and deeper and just relax. And then if there's a partner, I'll say, and now every time your partner touches you on the shoulder, you'll feel that wave of relaxation run through your body. Now, they use that 2 different ways. And I don't suggest this. The women work it out themselves. They will either use it during those surges, and they will just completely go out of it, and you'll see their breathing. They're just that breathing. Or they will do the breathing, concentrate on the breathing with their eyes closed, whatever. And then as they come to the break, they'll pass out. They'll think they had 4 hours sleep in 2 minutes. So, and some women do both, you know, but I don't tell them what to do. It just happens. So, and that's all coming into a room, just started shifts. Somebody's already, you know, just come in, and, you know, I had one the other day, just come in 2 centimeters. She was, I need an epidural. I don't do pain. I don't want pain. I can't do pain, blah, blah, blah. And I went, hold up. Okay. If you have this, and this, you know, chances are this can happen. How about we just try this? Well, she went on to have a baby. So, one had an abruption at 8 centimeters. So she'd come in with a bit of bleeding, but she was really early on with the abruption, but there wasn't a lot of blood. They weren't sure. So she went on 8 centimeters, and then all of a sudden we had a gush. So she did amazing though. She wanted an epidural when she walked in too. So it's just that focused state. It's really simple to do, It's just knowing how to do it. And it changes the entire birth experience, that 30 seconds. So
wow.
That
Well, and I
makes
know
sense.
you've been doing the hypnosis side for 5 years. Obviously, your skills are getting honed in, but what made you like which direction of training, or what did you feel was best for you to advocate specifically for the birth realm of certifications or focus?
Yeah, so I've always done it. It's something that I've done, whether it's because I did it with my births. Now, I never had any training in hypnobirthing. It was just what a woman does naturally. If a woman is left to do her own thing, if she's not brought into a hospital, if she's sat in a paddock somewhere and she trusts her body, that's what she does. She naturally goes into a trance. The women that come in that have lost their way don't know how to go into the trance because they're so scared about what's going on, what they're being told, leaving home, all the wives' tales, they don't. And so I've found, this is what I feel, that those women that don't go into that trance naturally, they're the ones that it just turns into a traumatic birth, unless they've got someone, because of all the intervention just continues because they go, yes, 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 to whatever they're being asked. So, so the reason I got the formal qualifications, I did the hypnobirthing course in Australia, because we had so many women coming and doing hypnobirthing that their births were turning out traumatic, and it was just not what I thought it should be. And I couldn't understand it. I didn't understand, well, if you're doing hypnobirthing, why are you coming in and having the inductions? Why are you ending up having seizures? Because you're out of control, basically. What I thought was that women were being told in hypnobirthing that there's no pain in there's no pain. So if you do hypnobirthing, you're not going to have any pain. It's going to be an easy, calm birth. And I just didn't agree with that. Now, I've had 13 births. And they'll tell you in hypnobirthing that, and I'm a qualified hypnobirthing practitioner, I've done a few courses, but they constantly telling the women that if you follow these, if you do this, you'll have no pain. So the women come in, and I found they were coming in and then they had pain, so they thought they'd failed. Instantly they went, oh my God, it's not working, I haven't done it right. And then they go into panic mode, the adrenaline rush, everything, and then it just goes downhill from there. And I watched this happen with other women. Like I was watching and I was talking to them saying, well, what happened and this, and then, being the doctor suggesting that we break your water, or we induce you because you live too far out of town, or your baby's too small or too big or whatever. So I thought, rightio, I need to go and get some more formal qualifications, because this hypnobirthing isn't working for me. I disagree with some of the stuff that they're telling me. So then I went and did hypnotherapist. So I studied and continue to study. I don't stop doing courses now. I'm addicted. So I did the hypnotherapy diploma, then advanced diploma with NLP, and then I've continued to do every course known to man, just because I learned something every time. So, but it was so that I could say I was the midwife hypnotist. So that was the reason that I did it. It wasn't because I didn't already have the skills, but now I can actually share it, because people, they see that qualification and think, oh, well, she knows what she's talking about. But it's something that any midwife can do. And I think if I step back 30 years, midwives, it was normal for a midwife to do it. Like the women that I trained with, when I had my first baby, that's what midwives did. But I guess, and I've taught students how to do it. And students have said to me often, I've never seen that, Michelle. This is a completely different birth that I've ever seen. Can I come in with you more often? So, it's just the way I work. It's just, that's the way I work.
Well, it'd be amazing, Michelle, if you're getting permission from a couple of the patients that you take care of to actually watch, like on top of your online course, to actually see it in action. Would be amazing for us to have part of it. So are there any great questions people have for Michelle, or we can dive into it? I personally am very curious about Australia and the midwifery regulations and the different provinces and how that works, but I'll leave this open to anybody who has questions about the hypnosis side.
Michelle, hi, this is Mary. I also did hypnobirthing with both my kiddos, and I do recognize what you said with that idea that if you feel pain, that all of a sudden you start to panic that maybe you did something wrong, and that you're not deep enough, or you don't have what you thought you needed to get through it. And so I do remember telling people when they asked me if I thought it worked, I remember saying that I thought it worked initially. And then all of a sudden, when things happened or changed, or you felt something different, then all of a sudden it was like, wait a minute, I don't know. But I guess what I wanted to ask is if, have you noticed with now, I don't know, I'm assuming you guys are wearing masks in the delivery rooms. Do you feel like with them not being able to see your face, is that a problem? I mean, I remember, you know, when I first started as a midwife, I mean, we were all told we were supposed to be wearing masks for the delivery as we're sitting in their crotches, but really quickly, I feel like a lot of us got rid of them because we wanted that face to face, you know, especially as they're crowning, you wanted to be able to you know, make that facial contact with them, to get them to watch you and to listen to what you have to say. Yeah. I guess I would worry that now with the mask, do you feel like there's a struggle to try and get them to relate to you?
I take the mask off in the room. So most of us do. However, in our particular hospital, it's different over there. Now, I'm in a country hospital at the moment, regional, so out of Brisbane, and we only just had the first case of a woman coming in positive, COVID positive, and I had the first one. It was absolutely ridiculous. It was the biggest joke I've ever seen. And, you know, we were dressed in the whole, you know, get up, which I don't know, I guess you guys have been doing all along, but I did that 9-hour shift and, you know, no one came in. I couldn't drink water, you know, because you couldn't drink through, you can't drink where you got all this on. It was laughable. It was so disastrous. And that woman, that was the one that had the abruption. So, and I just said to the nurses, I said, why can't I just go in there and take this off? Because this, I don't care. You know, I don't even want to be vaccinated. You know, over here, there's a lot of nurses that don't want to be vaccinated. And, I was happy to go in there, but yeah, you know, anyway, that's the reason. That particular case was the reason that I'm pretty well ready to walk away from the hospital, because the woman was not support. It was horrible. She wasn't allowed to have anyone come in. I complained and said her mother's downstairs. And I said, I'm happy to have her in. So because we're a little hospital, we got away with it and we snuck the mother in. Mm-hmm. So it really was horrible. It was horrible. The whole regulations around her. No one was allowed to come in. Once the baby was born, the partner had to leave the hospital. He wasn't allowed to come back. When she had the Caesar, they wouldn't even take the husband in. There was no communication. You know, there was nothing. But as far as on a day-to-day basis, we wear our masks around the coffee table that we're not allowed to sit around. So we have to move into a big room and we all wear our masks. But the minute I walk in with the patient, I take it off.
Yeah, and to give a preface, because you and I talked briefly, they've been locked down so much in Australia, like what we've went through with COVID the last 2 years, they're just starting their first cases, like they've been completely. So what we could explain to poor Michelle for the last couple of years is probably going to be her new norm the next couple of years. So,
well, see, here in Queensland, we locked all of Australia out, and Western Australia has only just opened. So people haven't been able to visit their family in Western Australia for 18 months. So if you lived in Western Australia, you couldn't come out, you couldn't go in. So if you lived in Queensland, we were like that as well for a long time. So my husband had to live in New South Wales because we had a business, and I had to live in Queensland, and for 12 months we didn't see each other. So I think actually they opened the borders for a weekend or something and then closed them. So I could just jump over the border, just the other side, and I saw him for a weekend, then come back. And so we were locked out of states to supposedly keep COVID out, whereas Melbourne and Brisbane were absolutely hammered with it. So
yeah. So I think that's what's interesting to us as midwives. I've been very passionate about expanding. How can we learn not just from each other in different states and different communities in the United States, but I was very excited Michelle wanted to talk just the culture of Australia and healthcare and midwifery and learning from each other and passing words of wisdom. So thank you, Mary, for the great comment. Anybody else have a question for Michelle?
Hey, Michelle, this is Deidre DeGrado. I'm one of the consultants with Midwifery Business Consultants, and I work in the Midwest. And my question was, my daughter's actually a marriage and family therapist, and she, her specialty is hypnotherapy as well for PTSD clientele. And in America, as far as I know, of course, anybody could do like the hypnobirthing class and teach that to, our clientele. But what kind of background do you have to have in Australia to get a certificate or whatever in hypnotherapy?
Nothing. So you can do a 3-day course. Anyone can do it. 3-day course, and you're qualified. Costs you $1,500 Australian dollars to go and do it. And this was what I think is the big issue that I was seeing. that these women who were going in, they had, had a hypnobirth, thought, oh, I can teach this. They pay the money and then they're qualified. And so then they were going in and telling women, you don't get pain, say no to inductions, say no to this, but the reality is we actually do need to have inductions in certain cases. We do need to have a VE in certain, so I can look at it and go, well, hold up, that's not warranted, because I can't, we have the information that we have, we know, and these women are going in, and I think that was half the problem. So that's why I've set up this birthing in trance, so that it's something quick, easy, that women, it doesn't matter if they've done their antenatal classes. So we don't pay for healthcare in Australia. It's free. Okay. So healthcare is free. If you had a baby, it doesn't cost you a penny. If you had a heart attack, it doesn't cost you a penny. If you want to add to it and pay extra, you could pay $200 or $300 a month and you get private cover. Now, if you lived where I live, private cover gets you nothing as far as the baby's born. You still go into the same hospital, you're treated exactly the same, there's no difference. So you can have your antenatal classes, they're free. Or you can pay to have your hypnobirthing classes. So this little thing that I'm doing, I consider it's a bonus. It's the bit that's missing in the hypnobirthing. In your antenatal classes, it's definitely missing. And if you have no education at all, it doesn't matter, because if you trust your body will do what it has to do. So you don't need to know about what hormone does what does. You just need to trust your body. And that's what this is about, giving them that place to go that just turn off. We've all seen 16-year-old girls come into birth, 15-year-olds. I've had 11-year-olds where they just birth because it's like, well, they don't give a shit about the world. They just, these 16-year-olds just do what their body does, and they just do it so beautifully. So that's, if people know how to go into a trance, into their own place. And I know hypnobirthing does that, but often women, they play the recordings, but they don't actually go into trance. They just
Yeah, I that's exactly what I've seen. And when people ask me about it, I often say, like, exactly what you said. It's identical to what you said, that the mom will say, like, I don't know, it just didn't work for me.
Yeah, exactly. So, same as they tell me, the gas doesn't work for me. Well, you're not using it right. Well, the hypnobirthing, and look, I've read the scripts and I've birthed 13 times. And sorry, but the scripts are willy-nilly to me. Oh, and as the flower open, well, yeah, no. I talk about, being empowered and all those sort of things. So I'm not a script person. However, I have put recordings together for each video so that, the first 4 or 5 are just about empowerment. They're learning to trust your body. So just trust your body, allow yourself to see your baby, those sort of things, and then we go on to, up breathing, down breathing, what you might expect. But if your body expects something else, do what your body wants. I'm not saying this is how you have to breathe when you have a baby. Everybody told me when I have a baby, like I birthed in the hospitals, but I went in, had my baby and came straight home within a few hours. And my husband and I birthed our babies. I didn't want anyone, I just leave me be. I want your bedroom here, but that's all I want. So I would come in and I would birth my babies. The midwives would every time say to me, oh, you can't sit up to have your baby. That's the worst possible position. And I'm looking at him going, my body's telling me to do this. This is what my body is telling me to do. I sit up like I am now. I bring my knees up and I birth my baby. And that's what's right for me. And I think too often, midwives, this ownership thing, are telling the women how to breathe, where to stand up, to have you squat, do this, whereas, you encourage them to move and all those things. But this trance is about your body listening. If the midwife says to you, go and sit on the toilet, well, I use this all the time. What is your body telling you? What's your mind telling you? Listen to your mind. Listen to what is the whisper in your ear, your unconscious mind. What's it telling you to do? That's what you need to listen. That's your innate ability to birth. So it's just made such a difference. I had birthed 7 of my grandchildren, all naturally. No pain relief, no intervention, no nothing. 7 out of 7. Like you find me 7 births out of 7 in a hospital that have no intervention. It just doesn't happen. I'm very rarely will any of the women that I care for have a cesarean. I had one recently, but she had an abruption, and we knew she'd had abruption before she come in, because the women, They just do it. And I'm not pumping up my own tires. Please don't think I am. I just know that it works, and I just know it's missing. So many, they're just missing it. That little tiny thing, just that little trance, that 30 seconds of going, breathe with me, do it together. They're in a trance then. As soon as you've got them doing what you're doing, and they're in that state where they're so suggestible, you've already got them. Hand on the shoulder and say, and just sink into that feeling as that contraction goes away, and close your eyes and just allow it to spread all the way to your toes. It's that simple. And
well,
then
you were mentioning you pass on to like the partner or support team to do the shoulder. Do you stay in the room the whole time, or do you gradually phase out? Like, what does that look like?
Well, so the women I'm talking about right now are women that come in with no experience, no education, so occasionally they've done hypnobirthing, but generally they've just walked into the room and here they are, and they're really not coping. If they're coping, I step back. Obviously I'll just step away. But the women I'm talking about, I will go, okay, there's 2 ways we can do it. And I'll just explain that to them. And so what I do is, as soon as I know that they're going into the trance, then I'll say to the husband, I'll say to the mum, and now every time such and such puts his hand, you'll feel that, and then he does it. And I might do it twice with him. And sometimes he'll look at me and say, and I'll just guide him or her or mum or dad or whoever's there. So I tend to use them as the in-between, because it's not my birth. Like, it's not my birth, like here, I don't know about there, but the ownership here of births. If I'm in the room and there's a 3-year-old that, I always encourage siblings. I had 9 at one of my births, so always had children at my birth. And I'll say to the mum, or I'll say, well, how about, little Sarah, how about she helps birth the baby? And so I'll put her up on the side of the bed, and here she is with her little hands there as this baby's born into her hands. It's just, that's what I do, because but mate, so many midwives here, nobody touches that baby. Like, it's the midwife's baby. Not even the mother gets to birth her own baby. So, being this trance, being able to say what you want when you want it, instead of being in that suggestible state by the doctors or the midwife and saying yes to everything they say, being able to close your eyes, take a breath, and know before you answer anybody what's going on in here. So that's part of what I set them up for, especially now with this birthing in trance, is I set them up for that. So don't make any decisions. Don't say yes or no to anyone until you've taken that breath. Take the breath. What's going on in here? What is your body, what is your mind telling you to do? Because you don't want to be forced into doing something that you don't want to do. So just take that breath. So I teach them, take the breath, and you'll instantly go to that place, and the answer will be there. And it does. Your unconscious speaks first, speaks quietly, and you always want to change it a little bit. So the answer's there. It's 100%, never not there.
Well, I think sometimes when our minds are so busy and there's so much influence on the outside, it's hard to listen to that other voice. So you kind of quiet everything else down, it seems like. So,
those external voices take over. That's right.
Yeah. Any other great questions people have for Michelle? Give him another couple seconds. So yeah, I would love, I know you and I talked before we started recording, just the difference of Australia and the United States and midwifery. So if you can tell us a little bit about your educational background and what types of midwives are in Australia, what are the regulations like? Just kind of give us a sense of how you can practice there would be really helpful.
So a few years ago, I can't remember how long, I don't know whether it's 5 or 10 years ago, they brought together all the states. So you used to have to be registered in individual states, and you are under different guidelines. We're all together now. So all Australia. So if I have my APRA registration as a midwife, I can practice in any state. I can jump the borders. We all practice in the same way. Some hospitals, like private hospitals, are a little bit different, but you can... In Australia, I've got a diploma, a postgraduate diploma of midwifery. So I did mine 20 years ago. Now they're bringing through masters and that, but it doesn't change your practice. It actually, we all practice the same. So there's no guidelines that change because of having a master's or because of having a graduate diploma. So our guidelines are the hospitals, individual hospitals that we work under. So as far as home birthing, any midwife can set up her own birthing. Some doulas do it as well. It's about your insurance. So it's about having your insurance that you're covered, otherwise you can't practice. So what I've noticed is quite a few of the girls that I've hypnotized because they were scared of the hospitals, usually because of traumatic births or something, have actually just birthed at homes with their husbands. So they just have stayed home and not gone to hospital at all, which isn't something that I support. And in fact, only one of the girls I knew was going to do that, but she had done it with all her children and her husband, they from Africa, and you know they knew what they were doing. But yeah, so we don't have that option of home birthing here. Like it's $10,000 to have a home birth.
Versus you can go to the hospital and it's part of your healthcare you're paying for. Yeah.
And there is, in the bigger cities, you will get birthing centres, and you would think they're expanding, but over the last 15, 20 years, they still haven't grown. There's still, you know, I mean, most hospitals don't even have, it's changing at the moment, don't even have water births. We don't have water births here. And then when they do have it, it can get so complicated that, you know, having all the hoists and everything, it's like, I don't know about you guys, but trying to get into the bath is breaking midwives' backs because the baths are organised so that this hoist can go over them, and it's like, give me back the little bath.
Yeah, I think in the United States, there's some similarities and some differences. Water birth is typically at a hospital setting. Most insurances do not pay midwives for out of hospital births. It's traditionally, especially with like government programs like Medicaid, where where you've got a lot of barriers accessible to midwifery in hospital setting. It's more, the insurance covers it with the Affordable Care Act, the government programs. So you have to pay. There's a wide range all over the United States, depending on cost of living and demand. So it can be as low as $1,800 in US dollars, all the way up to that $10,000 that you've talked about. I would say the average is $3,000 to $4,000 here. So there are barriers, very similar, but we still have, I would love to see a universal 50 states, national, and whatever education you have, this fits the scope, but we are far from that. We have many organizations for midwifery and we have many state regulations. So it gets very complicated to practice here. Mm-hmm.
Yeah, I'm lost in it. When you explained it to me, I just don't know how you all keep up. Like I'm thinking at the moment, we're talking about traveling around Australia. So we've got a farm, we're going to sell up, buy a caravan, and I can practice all the way around. I can just ring up the hospital and say, look, I'm going to be there for 2 weeks. Would you like me to come in? And I'll have work all the way around Australia in remote areas. And yeah, so in Indigenous, you know, I've been out, I don't know if you know Australia, but there's little islands off the top. I've worked on all the little islands, you know, so that's amazing. Like 2.5% Caesar rate at the Torres Strait, 2.5% Caesar rate.
Wow.
You know, because the women come in, they don't have pain relief. You don't, like, I remember one girl coming in, she'd flown in to work with us and she offered pain relief. And I looked at her and I said, no, these women don't have pain relief. They just birth. They just come in. And the Indigenous women are there that have been birthing for years. Their qualifications are they've worked at the hospital, and they just birth. It's just amazing. So there's no intervention at all. Just come in, have their baby, and go home.
Yeah, we would not be able to caravan around and just hop at hospitals. There's a few situations where nurse midwives can get locum assignments where they're covering like in a fill-in for maternity or sick leave. The hospitals coordinate an agency. It's a very complicated process, but yeah, it takes on average 2 to 3 months to get credentialed if you don't have a state license, all the insurances, all the malpractice. Like it's very complicated. If there's a new hire and a turnover, like they're hired full-time as part of a team that's either private, meaning like a physician, or a midwifery practice that has privileges, but many of them are employed by the hospital directly as a long-term relationship. So yeah, I was going to say, someone keeps talking about Canada, and I would love for Amaria keeps bringing up some differences. I don't know if she has a background in Canada, or it'd be amazing to have her bring her feedback in. Maybe she just wants to keep it to the chat. So no, what was the shift when you mentioned 10, 15 years ago, you had so many Providence rules and then it became a national, like what was the catalyst to make that momentum happen? I mean, obviously a few Providences in Australia are territories are completely different than 50 in the United States, but maybe it could inspire us. How could we make more of a universal regulation here?
I think it was just the push from the midwives. I honestly don't know. I wasn't really interested back then. I think it was a long push, like, because I remember they kept talking about it's going to happen, it's going to happen, it's going to happen. And then when it happened, and Australia, we all travel around and work around Australia. So like I was working in the Northern Territory, but had to have a completely different registration to go up there. And like you say, that can take 6 weeks, and they had no midwives. So places like the Northern Territory is quite remote. And, even to get to accommodation is very expensive up there, or it used to be. This is going back even 30 years when I worked there. And so it was, again, that was just another barrier why they weren't getting midwives. Whereas now, you can fly, I get a call. So I work for several different agencies now. And one of them is contracted to the federal government. They will call me, they will send me up there for 2 weeks on enormous pay. Like, it's ridiculous the amount of pay that I get to go up there. It's almost embarrassing to tell the other midwives. Because they can't get midwives. So they send me into remote Western Australia, like the most remotest community in Australia I go to. It's called Juttunjara in the Western Australia. And because I'm a midwife and a remote nurse, the government pays me all this money to go out there. So I can go anywhere in Australia now. Whereas I think the barrier was that parts of Australia just couldn't get the staff because of that. Yeah, and I'm not sure if that's what the push was, but
yeah, we do have similarities with the Indian health reserves, and if there are government funded facilities. So I've done some locum assignments in very remote parts of Arizona, and once you get credentialed and you get the initial process done, you can quickly go fill in for short amounts of times and been offered to me. So we do have some of that, but I would say that's such a minority of what midwifery options are in the United States. Most of them are community-based, private, larger healthcare organizations that are looking for long-term permanent support, because it takes, if they don't have a license in the state and they don't have all the certifications, things they need, even if you have everything, it takes at least 6 weeks just for the insurance side to get credentialed with all the insurance companies. So it's hard to fill in last minute for needs unless you're local and you really have already been established with a lot of the things they're looking for.
So who pays the insurance? If you go to work, is that covered by whoever you work for?
So we can have it combination of different ways. You could have a government program, the tax paying pays for that portion. You could have your employer pay for your insurance. You could have, the marketplace has gotten really big since the Affordable Care Act has been implemented. So people that are self-employed or don't have benefit options at work, there's certain criteria. So there's 3 options, and then some people just choose not to get insurance, and then they pay cash for their services and work out an arrangement with care and things like that. There's actually another option where it's growing more and more, the community-based insurance programs where you pay into it. It's called shared health plans. So there are options like that getting more popular, but I would say most of them are their employers or they're on a tax government program that's available.
Let's be clear though, even if you're getting health insurance from your employer, you are still paying a very large amount of money.
Yes, you still, when we talk about, you still have high premiums, and especially post-COVID, the healthcare share cost. It's gotten very, very expensive. They pay a portion of, as the employer, your health insurance, but you also, even if you're doing it with your employer, you still have to pay, depending on single person or family or couple, it can get quite pricey.
So everyone has to pay that?
Yeah, depending on if you're doing, and depending on the deductible, like it's not one same cost. So if you're going to cover out of pocket max higher, your cost should theoretically get a little bit cheaper when you're going to take more of it.
Yeah, so we've got the Medicare, and it's 2.5%. Actually, it might have gone up. It was 2.5% of your income, but your income's got to be up there to start that process. So so that just automatically comes out of your wages. So that's it's 2.5%, but overall here medical is free, because a lot of people are under that threshold where they don't have to pay anything.
Yeah. Some people are adding just the comments of healthcare is very expensive in the United States. It puts a lot of people in bankruptcy just because they can't afford the premiums. Medicaid and Medicare are the government programs, and you have to have an income level to qualify to be on those programs. And if you don't fit that income status, you either have to go to the marketplace and purchase it yourself, or you have to have an employer or just pay cash. So yeah, healthcare is a very big barrier in the United States. And a lot of people don't pick preventative services because they have just such a high deductible or thing to be met or don't have insurance. So
Gary.
And healthcare in each state, the minimum amount of money that you make is different as well. So what you make in Minnesota is different than what you make in Texas. Like you can make $40,000 in Minnesota, $40,000, $60,000 in Minnesota, qualify for Medicaid, but in Texas you don't qualify for Medicaid, and then you would make too much money to get on the marketplace to get your own. So there's donut holes too that are there in the states where people make too much money for Medicaid, don't make enough to get their own, and their employer does not supply it.
Yeah, the cost of living is extremely different in every 50 states. So you have these national regulations and then you have state regulations. And so I mean, all the midwives on here could tell you like their cost of living. Idaho is very different than California and Texas and Michigan. Like every state has very different. So we're trying to support each other, but then we have very different community needs, socioeconomic needs, cultural needs, regulations we have to follow. So it becomes a huge challenge to advocate and support midwives, even me doing the consulting services, because I talk, well, these are business strategies, but every state's different in how midwives can practice. There's some states that nurses and midwives can't own businesses, can't own private practices. They can't practice without a physician written collaboration. And some states, they're total autonomy. So it gets very confusing to know what you have to do when you're moving or you're living on state lines.
What would be the hourly rate for a midwife?
So I guess you guys can answer and I can give kind of the national averages I'm seeing. If you guys want to give ranges of just your local area, that would be great.
So in Australia, as a casual midwife, I'm taking home $52 an hour. But it's interesting. So that's a midwife, so registered nurse, a remote area nurse midwife, $52 an hour. But I'm qualified as a school teacher. So it's interesting that as a school teacher casually, I get 82.
Oh my gosh. Our school teachers make pennies to our dollars.
Yep, $82 as a school teacher an hour and 52 as a registered nurse midwife.
That is so interesting. Is the school system more of like a public government program or is it more private? Like what's the educational systems there?
More public. Yeah.
Okay. Yeah, so I would say our national average, if you work in the hospital, bigger hospitals, the nurse midwives make more. It can range from $40 an hour all the way up to $75 an hour. I would say the average is that 45 to 50, depending on benefits and how much, if you're a director or responsibility experience. Okay. Certified professional midwives, direct entry midwives, there is a wide range of what they make because 99% of them are self-employed or they work for another private out of hospital practice. So I do a lot. I do hundreds of consulting over the last 5 years. I've seen some midwives barely make anything and they're dependent on their husband's income because they love what they're doing. And then there's other midwives that are making $200,000 a year doing private practice. So there's such a wide range depending on how they structure things, their insurance in their area.
Yeah, we have that wide range as well. But, on an average, a normal nurse that's not, running, she's not the manager or anything else, we're sitting on 52. So when I go remote, I'm a level 5. And when I go remote, I can earn 80, but believe me, I am earning it. I'm in Indigenous communities and it's quite dangerous and so when you're stepping up, but just as an average midwife goes to work every day, who's post-grad by, I think 5 years, it's $52. Yeah, it's actually disgusting in Australia on level with other professions. Nursing profession is actually disgusting to pay.
Yeah. And it seems very similar. Go ahead.
Oh, I'm sorry. Are we talking the same dollar amount, Australian dollars and US dollars?
The conversion is slightly different. I'm trying to remember how different it is. We could talk about the conversion rate.
I
for
thought it
sure.
was it 80 cents to,
Which direction? In Australia, 80 cents is $1 or vice versa? I was going to look up the conversion.
80 cents American is, no, it's the other way around here. What is it? Yeah.
Is $1 Australian dollar. So it's like a 3/4.
Yep, I just looked it up as well. Thank you. It's $1 is 75 cents in the United States. So our $50 would be more like 70-75 to you. So there is a slight, we're getting a little more income conversion compared to you. But I was going to say, with locum assignments, when you're working somewhere, filling a need, remote areas, it is a little bit more pay on that higher end, like you were talking about. So
yeah, and even in the agencies, you go away, it's not that much difference. They're still getting that $52, unless, like, I contract to the government, which is a very specialised area, because they send you anywhere in Australia and you're only there for 2 weeks. So you go in so that the nurses or the midwives can get education, mandatory education, and they can't do it because there's no staff for them to
cover them.
no staff to, yeah. So that's why they ring me and they say, look, just 2 weeks in, remote, blah, blah, and I just fly in. So they pay me extra to do that because it's 2 weeks, people just won't do it. So, that makes sense. Yeah. Day to day, I still can't work out teachers are on 82, which makes me crazy. That's just a day-to-day teacher. That's just a teacher that's walks in off the street, completed a degree, not a principal or assistant principal. It's just walking in and looking after the class from 9 till 3.
I was going to say, our teachers, I think we'd have a lot of people going into teaching if we were getting those rate of pay here. It's not a good occupation in the United States. So any other great questions people have? I love the conversations and where we're going. We got about 8 minutes left of Michelle's valuable time. I guess I'm curious if nobody wants to add a comment or put something down below. When you serve the Indigenous community, can you tell us a little bit about the culture and like some unique birthing things that would be really interesting to us, or maybe some just stories?
Look, in this, we have 2 different cultures. So we've got the Indigenous, the Aboriginal communities, and then we have Torres Strait, completely different. So the Torres Straits are more part of the Indonesians, the Polynesian, and the Aboriginals are obviously native to Australia. So you're working in the Aboriginal communities can be quite unsafe. It's really hard to explain. And as you know, with their birthing, what happens is they're actually moved from their communities at usually about 38 weeks, sometimes earlier, and taken into a major hospital, into Darwin or into Alice Springs. So as a general rule, they're not allowed to birth on their homelands because there's no midwives. They've tried several different ways to try and change that, but it doesn't happen. So they ultimately end up birthing by themselves unless they're 16. Under 16, they can bring a family member with them. Sometimes they get to bring a family member. Yeah, they're placed in a motel style situation in town until they go into labour, and then they're brought in, they're birthed, and then they can go home. So look, it is changing. They're up in the Torres Straits now. They fly midwives in to fly out to the islands, and often sometimes those people just refuse. They run off. They go into the long grass, and so they birth. So that's when and it's such a privilege to birth them, on the floor in the back of the back of the car or wherever we are. But the men don't actually. 30 years ago, men just didn't come into the births. And sometimes now, but it is changing. The newer generations, they will have their partner in there. But for a long time, there was no men that came into the birth at all. In the Torres Straits, it was probably more like that. The men don't come. It's all family. It's beautiful. The Torres Straits on Thursday Island, when you have a birth there, it's the whole family. It's all women, aunties, cousins. It's amazing. And they have this beautiful tradition where a baby is passed to another member of the family. So, and it seems to happen a lot. And I don't know what the selection criteria, and they wouldn't tell us anyway, but they'll often have this baby and then it's just handed to an auntie or a cousin or someone, and it's taken to a different island. And it's grown up as they always know who their mother is. They'll always know, but they're grown up, as they say, by, that auntie on a different island. So, and they say that it's to do with, the islands, if they're all, they're all
The hereditary line trying to.
Yeah. So that's quite, they do it in New Zealand as well. So it's lovely to see, and it's lovely to see when a girl comes in who auntie's red and her natural mother is with her, and it's so, yeah, that's beautiful. So Thursday Island is by far the most amazing place I've ever worked. It's on the water. It's a tiny little island. And all the islands come in there to birth and for anything, So one of the islands I worked on side by, it's only 4 kilometres from Papua New Guinea. So it's a little canoe ride, So we often had girls over there that, 14, they have their babies over there, 14, 15. And we had one girl come over and she'd walked for 3 days in the tropics and all to get to a canoe to come over, because her baby, it was shoulder dystocia, and the baby's head was already born, and she walked for 3 days to get, she didn't die, she wasn't septic, she got in a canoe, they brought her over, got a helicopter and got her back to the hospital, and the baby was dead, obviously, but it like the things that you see are just so amazing, because Papua New Guinea, they don't have the health service, the Western Province, and that it's like, the tough live and the rest die. So yeah, so some of the things you see are absolutely amazing. The people are amazing, and it's by far, if ever you get to work in Australia, the Torres Strait is the place to go.
Very cool. Well, it makes me think, relatively speaking, if we complain about our poor healthcare and complain about inaccessibility to things, all I'm going to think about is 3 days walking and then riding a canoe afterwards. Like, yeah, we've got some barriers, but not nearly those barriers.
And how did she live? Like, none of us, the things that you see, you just go, how did they survive that? Like, it's just incredible. So yeah, that was yeah, it's just one of the things, like the things you see, you just go, oh. I just wanted to go and practice in Papua New Guinea after that. I just went, no, I just got to go over there, that, like, I've got kids and, so it just didn't happen, but maybe one
We
day.
just need more midwives. We'll keep training and getting more midwives out there so we can get them on all those beautiful islands. So, well, thank you so much. Anybody want to add some last minute things to Michelle? I appreciate you joining us. We've got a couple minutes left. No, I had a lot of fun, and thank you again, Michelle. And if you want, put in the chat box, and I'll leave it open for a little bit, your email if people want to reach out. Where's the website? I know you're very close to getting this online course done, and I know the midwives would be very interested in the United States to learn from a different style, because I get that same sense everybody was talking about with my last two kids. I did the hypnobirthing, and it worked so with the second, but it didn't work at all with the third. Thank you so much for adding that to the chat box, so people can reach out to you, pick your brain, see if we can help out more on an international level each other. So thank you again.
Thank you, everybody. It's lovely to hear how it works over there. I'm going to come over shortly for a visit. I think I just got to get.
Oh yeah, please let us know. I would love to. We can have you co-host or speak at a conference if you're coming. If you're going to go this direction. So.
Oh gosh.
Well, only if we're all allowed to come in exchange.
Exactly. We'll do a conference in Australia. We'll get a whole plane together. I love it. So yeah, so michellebrain.com. So that makes it super easy to find your resources.
Yeah, and like I'm the midwife hypnotist on everything else, but I've just this birthing in trance it will have a funnel to go to it. So it's that's sort of going at the moment, but it's really simple. It's aimed at, like I said, it's aimed at women. But I've already got hypnotherapists and everything asking me to be able to do it as well. So hopefully it's affordable. It's not going to be, out of the price range for anybody. So, but yeah, enjoy. Okay. But if you want some tips on it, or thinking about, just Zoom me, give me a message. I'm happy to show, go through it with anyone. So
Yeah. I think the biggest thing is taking it, and maybe some people that are in the US that have taken it, if they've got some feedback or application, now they're trying to use the birthing and trance in their hospital local setting. It would be great to have some support, maybe quarterly or something we would do for your followers that are testing it and seeing if it works really well in Australia, but what are the cultural barriers or the healthcare system barriers to implement this? We can work out.
And that's
together
what
for sure.
the trick of it is to not use the words. Because really, all you do, it's breathing. It's focused on your breathing. So let's focus on your breathing, and just relax, because some words you can't use, you can't use hypnosis and you can't use, So, but at the end of the day, I've been using it for, like I said, 30 years, and there's never been a word attached to it before. It was just the way, it was my technique. So,
Perfect. Well, thank you, Michelle. You have a great morning, and everyone else, most of everyone, it's their evening. So thank you for joining us. And if there's any other, send an email to empoweringmidwiferyeducation.com if anyone wants certain topics or feedback or wants her to come back and focus on something. I love getting responses and feedback from everyone.
Thank you. Thanks for having me, everyone.
Bye-bye.